Hello everybody, this is Dr. AUSTINBLANCHON. I'm a chiropractic physician. In today's video I'm going to be explaining what a disc herniation is and what this terrible back pain that we call sciatica is. So stay tuned for this entire video. Now, so what a disc herniation is, it is otherwise known as a slipped or a ruptured disc, or even a protrusion of the disc of this jelly-like fluid into the surrounding spinal canal. And some of the causes that can cause a disc herniation can be absolute sudden trauma to the spine, as well as some poor posture over time, as well as degeneration of the vertebra in the joints that can cause a shrinkage of the joint space that pushes on these discs. These discs are jelly-filled cushions that are between the vertebra that help with shock absorption. Whenever you have something in the center of this jelly-like disc that's protruding outwards through the very tough layer of the disc, when it protrudes out, it's going to be affecting the nerve roots that come out of the spinal canal. Now, lots of people have heard about cervical or neck disc herniations and lumbar or lower back disc herniations. Typically, the disc is going to herniate into the backwards and lateral portion, as well as into the lower portions of the neck and the lower portions of the lower back, where there's more repetitive strain. This is where the disc is going to herniate and can cause numbness into the fingers and the toes, weakness into the hands and the feet, as well as tingling throughout the arms and throughout the legs. Now, when these get super serious, you can have an impact in your own bowel function. Something caused numbness into the saddle area called saddle paresthesia. The saddle area is the area that, imagine you're riding on a horse, and that is the saddle area where your body is meeting the horse. This can affect things, as serious as you going to the bathroom, being able to have your bladder control. There's a spectrum of how severe these disc herniations can be. Some are very minor, some can be very severe. Now, so your treatment options are going to be obviously getting first good diagnosis. You can seek a physical therapist, a chiropractor, or your primary care physician in a medical facility to get a best diagnosis. Diagnosis can include a nerve conduction study to make sure that there's no extreme pinching of the nerves. You can also get some sort of MRI scan, and a X-ray might need to precede these things, but typically X-rays are done for more bones, and a disc herniation, because the disc is jelly-filled, is more soft. So an MRI or a CT scan potentially could be warranted for this. It might be necessary for a diagnosis, but not always. In the few years that I've been a chiropractor, I've seen many disc herniations. I have not had to send out for many MRIs. Only a handful of them. Therefore, there is treatment options for these disc herniations that are going to include, lots of the times, traction therapy, specific lifestyle modifications, as well as manual therapy that's going to help restore the mobility in the body and promote healing. Because you're having damage to the surrounding area if you have a bad disc herniation, and your mobility is going to be impacted because your body is trying to protect a very small area of the spinal canal from being injured further if you move into specific ranges of motion. I have exercises in the description of this video that you can follow along if you have severe back pain. You will not necessarily know if it is a disc herniation or if it is sciatica. So look in the description, you will find exercises that you can do. If these exercises don't help, then search for your local chiropractor or a local physical therapist. Go to them as a primary care physician for your back pain. Then from there, they will know what to do if they need to send you out for more images. Now, the causes of sciatica. It can be a disc herniation in your lower back. Let's say the fourth or the fifth lumbar vertebra could have disc herniations affecting what are called the sacral nerve roots. These can go all the way down and impact your foot function, etc., and your bowel function as well. Now, some things that can cause sciatica can sometimes be known in the elder population. It's called spinal stenosis, or stenosis is referring to the narrowing of the spinal canal. These are the people that you might see that typically round their entire back and that they walk like that. These are the people that when they round, they're actually opening up their entire spinal column to allow for the circulation to be better throughout the nervous tissue. That is called your sciatic nerve. because it's the largest nerve in your body is going to protect it at all costs. The elder individuals that might have the spinal stenosis, some common complaints are that they need to sit down quite a bit just to rest, and they notice that sometimes rounding forward can help with the pain, and when they extend their spine and be more upright, that can actually cause the pressure to be more intense in the spinal column, and it causes pain. So these are the people that chronically walk, let's say with a cane, or they need to hunch over. That is a common sign of spinal canal stenosis, but that would need the X-ray diagnosis to further identify. And spinal canal stenosis, it is treatable with more of the conservative care, the traction therapy, manual therapy, lifestyle modifications, exercises, etc. Other things that are very common to cause sciatica because we sit down so often, it is something called piriformis syndrome, or these are the hip rotator musculatures that you will see here that span from certain bones that are nearby your sit bones. Now lots of times, because we're sitting so much, these muscles get very squished, and we're not moving as much as we typically would like to. We're not rotating the hips too much. We're not treating ourselves as if we're a professional athlete and always making sure our hips are nice and open. So these muscles can compress on the sciatic nerve. Because this sciatic nerve's anatomy, it actually penetrates on a lot of people, but not everybody, through this muscle called the piriformis or the other nearby muscles. These muscles kind of make a fan. There's a bunch of them that weave through here. My fingers are the sciatic nerve. They need to penetrate through the muscle. Sometimes they embed right in between the muscle, and they have to travel through the muscle. So you can imagine so much congestion in that muscle on the surrounding layer of connective tissue that acts like wrapping paper. It's extremely tight around that nerve. It's going to get choked off. And again, that's a spectrum. It can be very minor, it can be very severely choked off. When things are choked off, they're really squeezed. Imagine you have this huge tourniquet around your arm. If it's only moderately tight, you can last for a decent amount of time before it starts to feel numb or tingly or even change color. Now, if you severely wrap that thing, it's only a matter of time before this thing can potentially start to go completely white and lose circulation and literally cut off and actually die, and you need to get it amputated. And then again, it can be lightly compressed. Lots of us might just have light to moderate compression of this piriformis muscle on a day-to-day basis. Therefore, a big antidote of this is going to be manual therapy. So that's massage work, that's active release technique, that's pinning the muscle down and stretching it. This is doing stretches such as the pigeon pose on the ground or doing pigeon pose on an elevated surface. And again, looking in the description of this video and you'll find many exercises how to relieve your sciatic nerve. There's those specific stretching straps that you can stretch the sciatic nerve with. And again, the stretching can help for some people, but not everybody, to help alleviate sciatica if it's going to be related to this piriformis syndrome, etc. I have found that diagnosis to be pretty common among the patients that I treat. Now, associated with more of the degeneration sides, if you've had degenerative disc disease. Now, this could be something such as an autoimmune issue because your disc or your own body, and sometimes autoimmune issues can attack the spine, so that is a possibility. Physical trauma can also cause a disc issue when you're younger, and then it starts to degenerate quicker because it's starting to age quicker than other parts of the body. So degenerative disc disease can cause a slightly decreased space in the joints because it's called your discovertebral joint that is actually a joint. So if you have less space in a joint where there's supposed to be space, therefore that can cause compression of a nerve immediately running up and down the spine, and that's going to affect everything further away from it into the legs. When it's extremely severe, you can have loss of bladder control and bowel control. Now, this is more on the rare side. I myself haven't had any patients that have had complete loss of that, though they have had referral pain into that area, because this has to do with how we were born and raised in our mothers in the uterus, is how we were developed. It has to do with all of these specific what are called germ layers, etc. Endoderm, mesoderm, ectoderm. Certain parts of our body start to form with other parts. So when there's a lower back disc herniation, I've had patients that have had referral pain into their testicles. And this is just because the nearby organs, they come out of that body part, but they once started really nearby that area, so that nerve in that spinal cord area, we're actually innervating that area. They're very connected. But then as we start to develop and grow, obviously things have to kind of grow out and make space, and they make their own anatomy. So therefore, when you compress a nerve somewhere in the body, based on how it was developed, it can cause issues in the nearby areas, even though when we're adults, these organs are not necessarily directly associated with it, but they're indirectly associated with it. I hope that makes sense to you, but it's just going to show that disc herniations and things that affect the spine can affect many different other parts of the body, and it can be very complicated as to why it happens and how it gets there. But I hope that that correlation of how we were developed can potentially get you there. Your doctor obviously knows this. They've been trained in human development because it's very important, so they can identify specifically what's going on with your referral pain, because sciatica is actually an overused diagnosis that patients come up with because it's very common to search on Google and WebMD, etc. So lots of people will say they diagnose themselves with sciatica because they just have some achiness in their lower back and it's somewhat in the glute. Lots of times this is because we just sit down too much. That's, in my opinion, for educational purposes only, the most common reason as to why people have more of this pseudo sciatica. But still, lots of people, they do have sciatica. I hope that gives you a good illustration of what disc herniations can be in the body and what sciatica is, because this back pain, whether it's associated with a disc herniation or sciatica, is very, very common in today's society. People will experience it probably a few times in their lifetime. If not, people are going to be chronic pain because of their back. So I wanted to shed some light on this, and I hope you do appreciate this video. And stay tuned for more videos, and you can again look in the description of this video and you're going to find more videos that are going to be exercises and then ways to massage your body to help alleviate some of this agonizing back pain that we all have experienced.
The same thing? No, there are some distinctions here, and the two most commonly used terms to describe an injured disc in medicine are bulging and herniated discs. A bulging disc is when the outer portion of the disc, that annulus fibrosus, is bulging outward. Yes, I understand it is earth-shattering to say a bulging disc is bulging outward, but there is an important distinction here. With a bulging disc, the annulus fibrosus remains intact. Just think of it as kind of getting smashed and stretching outward. But one of the best analogies that I heard to describe a bulging disc, think of a hamburger where the meat patty is too big for the bun. And the bun, the top of the bun, and the bottom of the bun would be the bones in this analogy, and the meat patty extending beyond the margins of the bun would be the disc. And it doesn't have to involve the whole circumference of the disc. It can, but many bulging discs just include anywhere from 25 to 50% of the outer circumference of the disc. So you can maybe think of it as 25 to 50% of the meat is only extending beyond certain margins of the bun with our wonderful food analogy. Now, bulging discs tend to occur with age, as that cartilage becomes more dehydrated with age and those tissues lose some of their strength and integrity. A herniated disc, on the other hand, is when that annulus fibrosus actually gets cracks and tears in it, which will then allow the nucleus pulposus to protrude outward. Now, a herniated disc is synonymous with some of those other terms like a ruptured or a slipped disc. Now, this often occurs with certain acute injuries, say somebody lifts improperly and they rupture or they herniate the disc.
Now, lots of times I've had patients, they sometimes experience a popping sensation. Now, this could be from what they were talking about in the video, if it's bulging or if it's herniating, depending how severe it is. You saw in that depiction what it looked like. It's pushing on the nearby joint. The joints that are just behind it, those are the joints that make that popping sound. Those are called the facet joints. Those are the joints that whenever you crack your back, that's typically what's making the sound. When there's so much pressure being put on it from the internal portion of the disc pushing out, that can cause that popping sound to occur. It can, but not always. You don't necessarily have a disc herniation or a disc bulge when you bend over and you pulled your back and you heard a popping sound. It can be just that you overstretch that joint or compress that joint, either or, that can make that popping sound. Or it absolutely could be a disc bulge or a disc herniation pushing on that area, and it's going to cause some pain because the nerves are very, very close to that area. And you can see that those contents of that disc, they're not supposed to bulge out into that space. Our body is very particular with where it puts body parts. The nerve is in one location and it needs to have space. That disc is where it needs to be, and it should be pushing out into that vulnerable spot. Now, in the depiction, most disc herniations go backwards or posterior or to the side or lateral. So it's posterolateral disc herniation or a disc bulge is very common because that cartilage that is on the back lateral portion is more thin there than the other body parts. So it's just our own anatomy has a weaker spot, so to say, and that's where it gets herniated. That's could be a reason why lots of us get back pain in that specific spot, where it's just slightly to the side of where the vertebra is, but it is obviously on the back.
But keep in mind, an aged bulging disc is also going to be more at risk for herniation. Now, a herniated or bulging disc has got to cause a lot of pain, right? Well, yes and no. For example, there are situations where, say, someone went in for imaging for like an MRI that had nothing to do with back pain or a disc issue, and they just incidentally find through that imaging that the person had a couple of bulging discs that they weren't experiencing pain from. Compare that to something.
Yes, now that is very common. Lots of people can have bulging disc or even tears on their ligaments, tears on their tendons, or even minor muscular tears, and they don't actually experience pain at that current moment. They could have at some point, or they just push through it because they have a very strong nervous system. They're not necessarily focusing on the pain at that moment. That's very, very common. I've had many patients come to me with specific images, MRIs, that show these things. Oh, you had a disc herniation at some point, but it's not necessarily why they have pain at that moment. But it's hard for clinicians to sometimes decipher. Therefore, you need to be very particular with what you're looking at to see if this was something that happened recent or did this happen many, many years ago.
Compare that to something that happens more suddenly. Say someone is lifting something improperly and they herniate the disc right then and there and feel that immediate pain. Now, there's some reasons for these distinctions here. One is that the discs actually don't have a ton of pain receptors. And because there's not a lot of pain receptors, it typically is going to take something a little bit more severe and more sudden to really get those pain receptors fired off. So that gradual bulging of the disc that can happen over time, as long as that bulging disc doesn't irritate surrounding structures, it could potentially go unnoticed. As compared to that other situation where somebody's lifting and they tear that annulus right then and there, rupture the disc, that's going to cause that immediate pain. But even still, a lot of the pain that's associated with it, sometimes it's the majority of the pain that's associated with disc issues, is when that bulging or ruptured disc irritates or compresses surrounding structures. Those surrounding structures could be blood vessels, ligaments, and of course, the nerves. The intervertebral discs are in close proximity to spinal nerves, which originate off the spinal cord, and the spinal cord is located within the vertebral canal, sometimes referred to as the spinal canal. These nerves will exit the canal through a hole called the intervertebral foramen. And again, this is in close proximity to the discs. Now, disc bulging or herniations and the potential collateral damage that they can impose on the spinal nerves could happen at any spinal level that you would find a disc. And remember, we said that was from C2 down to the sacrum. Now, these principles of nerve irritation and nerve impingement can generally be applied to, again, any level where you'd find a disc. But we're going to focus in on the most common areas where you find disc bulging and disc herniations, and that's in the lower lumbar region, specifically L4 and L5. So here we are zoomed in.
So now, lots of us that experience this L4, L5 pain, these are very nearby where your back dimples are, where the tailbone is, kind of very similar to the area that you feel like when you're sitting down, and it's the closest portion to the bottom portion of your backrest. That typically is going to be where your L4 and L5 area is. Very, very common spot for us individuals to experience some sort of back discomfort at any given point in our life.
So here we are zoomed into the lumbar spine of Cornelius' skeleton. You can see the L4 vertebra, the L5 vertebra, and the sacrum down below. You can also see the disc between L4 and L5 and the disc between L5 and the sacrum, and of course, the L4 spinal nerve, the L5 spinal nerve, the S1 spinal nerve, and even those S2, 3, and 4 spinal nerves down below. So let's say you have a bulging or herniated disc that's compressing or irritating that L5 spinal nerve, or maybe even the S1 spinal nerve. What would some of the symptoms be, and how could you figure out what specific spinal level or spinal nerve is being irritated or compressed? Well, you can go straight to an MRI, but I feel like that's a little bit of cheating, at least to do initially, because a skilled clinician can actually get a pretty good idea of what specific spinal nerve is being compressed by doing some testing just in the office or in the clinic. There are these things called dermatomes and myotomes. A dermatome is an area of the skin that's innervated or served by a specific spinal level or spinal nerve. So there's L5 that controls a specific area of the skin. S1 goes to a specific area of the skin. So the clinician would test those specific dermatomes associated with that spinal level for things like numbness or tingling or other abnormal sensations. Often the pain can radiate to those areas as well.
So now it's very common that the dermatome testing could be done whenever your doctors use one of those pinwheels and they're just going into these general patterns. Some people have disc herniations or disc bulges and they don't necessarily experience those positive findings within the skin because lots of times you might have distorted feelings in the skin, etc., whether or not a nerve is compressed or not. But it can be a good indicator to specifically identify which areas of the spinal cord is being compressed, and that's affecting which specific nerves because of the patterns of these dermatomes.
There's also the myotomes I mentioned. A myotome is a group of muscles that are innervated by a specific spinal level. So you could test those muscles that are innervated by, say, L5 for maybe some weakness. The challenge of that muscle testing is the majority of muscles in the human body are innervated by more than one spinal level. For example, the hamstrings are innervated by L5, S1, and S2. So if the L5 spinal nerve is being compressed, the hamstrings would still be getting signals from S1 and S2. So that might be harder to tease out if there's any weakness in that muscle when you're comparing like the good side to the bad side. But whenever we talk about rupturing, herniated, or having a bulge disc in these lower lumbar areas and compressing nerves like L4, L5, and some of the sacral nerves, we have to have a discussion about sciatica. The term sciatica is used to describe pain that's radiating along the pathway of the sciatic nerve, and it's going to be caused by compressing a nerve root at L4.
Yeah, you can see in the depiction of the backside of that little figure that obviously those red things were kind of signaling that the lowest portion of the spine then has the nerve roots that then start to form what are called the nerves, and then those are starting to go all the way down into the legs. And then all of these things kind of branch out like you see branches on a tree. But if you affect anything in the center of that, it's going to affect all of the branches on the outside portions of that. So when they're talking about sciatica, it is a very used common diagnosis. sciatica can be a manifestation of a disc herniation.
L4, L5, S1, S2, and or S3. The most common cause of this is having a bulging or herniated disc below L4 or below L5, compressing one or more of those 5 spinal levels that I just mentioned. Now, what's interesting is that many clinicians actually prefer not to use the term sciatica when discussing these issues and prefer to use a term that's a little bit more accurate called lumbar radiculopathy. Radiculo just means nerve root, pathy just means disease state or an abnormal condition, and sometimes they'll use the phrase lumbosacral radiculopathy if a lumbar and a sacral nerve root is being compressed or affected. And so the reason for these distinctions is that when you compress one of these spinal nerves through a herniated or bulging disc up at this region, the sciatic nerve hasn't even been formed yet. The sciatic nerve forms lower down in the pelvis, and it gets contributions from these 5 spinal levels. L4, L5, S1, S2, and S3 all send branches or contributions to form the sciatic nerve lower, and that sciatic nerve will emerge in the gluteal region underneath a muscle called the piriformis, and then will continue down the back of the leg. So you can see why, if we're just affecting, say, the L5 spinal nerve, that's not technically compressing the sciatic nerve yet, and so that's why some prefer that distinction over just calling it sciatica, even though the pain can run down through that sciatic nerve.
Now, very good depiction. So this is something that your doctor might use in their insurance diagnosis codes, is use some of those radiculopathy things. The radiculopathy portion is going to be affecting when it's straight coming from the center, whereas let's say one of these is what we call a peripheral nerve, which is a sciatic nerve, or even it could be your median nerve, or a radial nerve, or an ulnar nerve, is that your clinician is going to have a specific meaning behind that, which is very important because sometimes people have sciatica and it's not necessarily coming from your spinal cord or the center of the spine, but it's coming from, let's say, the glute area or the hamstring area, and it's just referring pain either upwards or downwards because there's specific connections in these nerves where the term would be called anterograde or retrograde. This is how the nervous tissue can refer to things that are below it or closer to the feet, above it or closer towards the head. Even if you have a nerve issue that's in the hamstring area, the back of the thigh, that's where the sciatica nerve also goes through. If you have a nerve issue that solely got there due to, let's say, a hamstring pull or a hamstring strain, this can cause achiness into the back. Vice versa. If you injure your lower back and it's solely pinpointed right at the spine, this again can cause that weird kind of shooting pain that goes down the back of the leg, sometimes past the kneecap or past behind the knee, and it can go down into the calf region. It can go towards the big toe side or the pinky toe side, and sometimes you lose the ability to kind of walk up on your tippy toes, etc. So it's very important to know that there's so many things that can go on, but they're very right. A good, skilled clinician can figure this out most of the time without imaging, but sometimes might need some imaging to specifically see how severe whatever is going on with the sciatica or other nerve issues.
Now, there's 2 other things we have to cover here. One is you might think that if we had a herniated or bulging disc below L4, that it would actually affect the L4 spinal nerve. But typically it doesn't. It actually compresses and affects the L5 spinal nerve. Why in the world does that occur? The other thing that you might have been wondering or thinking, we've talked about compressing sacral spinal nerves. If you look down at the sacrum, there's no discs there. So it obviously has to occur from here or here, but how is that happening? Well, to help us understand those questions, that is a story of development while you're developing inside the cocoon of love that we call the uterus inside of mom. So this developmental story is specifically about the spinal cord, and this picture is going to help us with that story as well as help to answer the questions that we just posed. So let's orient ourselves to this picture. This is a posterior view of the lower spine. You can see the L4 vertebra, the L5 vertebra, and the sacrum, and then we've got these nerve roots coming down. The blue are the lumbar nerve roots, and the red is just representing the sacral nerve roots.
And they do a very good job at beginning, very getting particular because they give you lots of good education for the beginner, but they also go pretty in depth because they are very well knowledgeable. But all of this stuff does matter because lots of my patients, they start to become more informed about this because they have serious issues in their spine. They're going to start to live with this, so they need to be understanding of what's going on, just how I needed to learn this in chiropractic school because I see back pain every single day, so I need to know this extremely, extremely well. And they do a very good job at articulating what's going on, and I remember learning about this in chiropractic school because sometimes things aren't as simple as one would seem. A lot of it has to go with our human development and just how anatomists, people that study anatomy, have named things over the years, etc.
I did mention this is a posterior view, so in order for us to see these nerve roots, we have to do some cutting. So we have a L5 vertebra to show you here, and so in order to see those nerve roots, we would have had to cut here, as well as here, and pull that segment of the bone off so you can see those nerve roots running through that vertebral or that spinal canal. We've even got a little makeshift cardboard disc where we've got a poor little nucleus pulsus herniating out, and we'll talk about that in just a minute. But You might be thinking, well, we're looking in the spinal or vertebral canal here. Shouldn't we see the spinal cord? And the answer is no. The spinal cord in an adult actually ends at L1, L2, right at the superior border typically of L2. In an infant or newborn, it goes down as far as L3 and L4. But what you're seeing is that the actual spinal cord segment, say like the L5 spinal cord segment, isn't lining up with the L5 vertebra or bony segment there. Now, that wasn't always the case. When you were developing inside mom, there was a time where the L5 spinal cord segment did line up with the L5 vertebral or the bony segment there. But something occurs called differential growth. And what that means is that the vertebral column or the spine grew faster than the actual spinal cord. And so to accommodate that differential growth, these nerve roots had to grow out longer and to again accommodate that differential growth between the spinal cord and the actual spine itself. And so this group of nerve roots actually got a name called the cauda equina, as it resembled what they thought of a horse's tail. But this anatomy and these relationships will help us answer those questions that we posed.
Now, you can definitely see that in that picture, when they were talking about the cauda equina, that horse's tail, you can see whenever you feel a horse's tail or even your own hair, there's all these different fibers that make up it. So the cord, if you break it down to the individual level of the neurons, you think of it just as one big bundle, but there's a bunch of little nerves, really, that are very spaghetti-like. They look like spaghetti, they're kind of squishable. There's so many of those that they then start to collect and then they can disperse throughout the body. And then that differential growth, it's very common that things that were in human development, in uterus, in our mothers, is going to be different as we start to age and get older and start to develop. Things need to differentiate. You kind of have to let go of the past and start to grow into a new future, so to say.
Remember we said a herniation of the L4 disc that's associated with the L4 vertebrae, you'd think that it would compress the L4 nerve. But I said typically that L4 nerve gets spared, and you can see from this relationship how that herniation I've drawn here would actually affect the L5 nerve. And if I come back to this little makeshift drawing that I have here, typically the herniations are posterior lateral, so posterior just slightly to the side, and that's how we've drawn it here, as well as down here. The disc that's associated with the L5 vertebra, or below it, you can see how it would spare the L5 nerve, but compress the sacral nerve. And that answers our second question, how can you have sacral nerve issues when there's no discs to herniate in the actual sacrum?
You can think of it as, let's say, the individual disc herniation. If it's an L4 disc, it's going to affect the L5 nerve root, and then an L5 disc is going to affect the S1 nerve root. So you get the bone that's above it, or less in number, it's going to affect the nerve root that's going to be below it.
The actual sacrum. Now, some of you might be taking this even further, thinking, well, what if that herniation was even greater or larger, or just even more central? And you can see if we just moved it slightly more medial or had more of a central herniation, you could affect even more of those sacral nerves. So hopefully this picture can kind of give you that idea, is at least give you that visual, how you can affect certain nerves, spare other nerves, and even affect more sacral nerves than you might actually anticipate, with no discs actually being in the sacrum. Thanks for watching, everyone. If you're interested in potential treatment options for back pain, including sciatica and disc injury, we covered some of that in our previous back pain video, so we'll link that to this video. Also, if you're interested in pursuing anything with yoga, check out the link in the description below with Yoga Body, the sponsor of today's video.
Now, that is my reaction video. They did a very, very good job about expressing this. I am very impressed with it. As a specialist of back pain, I definitely approve with everything they are saying. So, if you guys are interested in more reaction videos, you can look in the description of this video. You will also find specific exercises that can help modify some of your back pain. And then if those don't work out, then you can absolutely use my resources to help find clinicians that can help best suit you with your back pain.